Good morning. I, Shalvi Boralkar, would like to welcome you all for today's Physio TV session, an introduction to traumatic brachial plexus injury rehabilitation. I am honored to welcome and introduce our today's speaker, Dr. Raveena Ramakrishna Kini ma'am. Dr. Raveena ma'am has done her master's in musculoskeletal physiotherapy from MUHS. She has secured a first rank in GS Medical College and MUHS. Ma'am is currently working as Assistant Professor at MGM College of Physiotherapy, Navi Mumbai, and has a personal clinic dedicated for patients of underprivileged strata. She is also a certified medical writer. Ma'am has received multiple scholarships and awards, like Sir Dorabji Tata Scholarship thrice during her Bachelor's of Physiotherapy, Vice Chancellor Merit Certificate MUHS Nashik. She was awarded a gold medal and certificate from Mumbai branch of Indian Association of Physiotherapy for securing first rank of Masters in Musculoskeletal Physiotherapy. She received a Challenger in Clinical Expertise Award from Physio Times in October 2021. Ma'am has worked in multiple clinical setups like GSM and KEM Hospital, Ramakrishna Mission Charitable Hospital, and Safi Hospital as a clinical therapist. Ma'am is also very keen on research and has published more than 10 research articles. I would like to welcome you, ma'am. Over to you.
Good morning. Welcome to Physio TV. It is an utmost privilege to present this topic, traumatic brachial plexus injury rehabilitation, here. Before I begin with the topic, I would like to express my gratitude to my guide and mentor, Dr. Chaya Verma ma'am, under whose guidance I have learned a lot about traumatic brachial plexus injury rehabilitation. I would also like to express my gratitude towards my HOD of MGM College of Physiotherapy, Dr. Vrushali Panhale madam, under whose support and encouragement I have been able to do this. I would also like to thank the patients of traumatic brachial plexus injury, because I got the privilege to treat them and learn a lot from them during my budding years. So before we begin, I just want to give you a brief of what we will go through. So the first part would be an anatomy, a brief, then how about assessing these patients, a little into the surgery, and eventually we will come to the rehabilitation. So the first part, as we start, so we all know about the brachial plexus injury, the anatomy. It's one of the integral parts that is there in the first year. So we all read about it mostly. So C5, C6, C7, C8, and T1 basically constitute the brachial plexus roots. Sometimes there is involvement of the C4 nerve root, which is why it is called the prefixed plexus. Sometimes you have the T2 nerve root, which is the postfixed plexus. Now from the roots, we have two nerves coming, which is the dorsal scapular nerve given to rhomboids, that is C5, and the long thoracic nerve, which is C5, C6, C7, which is given to serratus anterior. So now these roots get divided into trunks, which is your upper trunk, that is C5, C6, the middle trunk, that is C7, and the lower trunk, that is C8, T1. So now the upper trunk also, you have two nerves coming out, which is the suprascapular nerve, and you have the nerve to subclavius. So then there are multiple divisions that happen. And then we have cords, which are the lateral cord, the posterior cord, and the medial cord. Now from the lateral cord also, you have the mnemonic 2LM, which means one lateral pectoral nerve, the lateral part of median nerve, and the musculocutaneous nerve. Then for the median nerve, we have the medial cord, we have the mnemonic 4MU, which is 4 M's, that is medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial part of medial nerve, and the U stands for the ulnar nerve. And then eventually you have the posterior cord, which gives rise to the upper subscapular nerve, the lower subscapular nerve, the thoracodorsal nerve or the nerve to latissimus dorsi, the radial nerve, and the axillary nerve. So this was a brief about the anatomy. And we need to know this before we proceed into the assessment and rehabilitation of these patients. So just a human dissected part of the brachial plexus, which shows that this is the C5, C6 nerve root, the C7 nerve root, and the C8, T1, which all branches into the upper trunk, which is C5, C6, the middle trunk, which is the C7, and the lower trunk, which is C8, T1. Okay, we go to the next slide now. So now, before we go into other aspects, we need to know the types of brachial plexus injury. Okay, now types, now based on the extent of injury, you can have a partial or a complete brachial plexus injury. Partial means what? Only the upper trunk is involved, say like in this case. Okay, or say the lower trunk is only involved. Okay, or only a segment is involved. Some muscles are spared. That means your partial injury is there. But complete injury means all the nerve roots, that is your C5, C6, C7, C8, and T1 are involved, and all the muscles which are supplied by the plexus, okay, absolutely show you no response or no contraction. That means there is a complete brachial plexus injury, or as we call it, a pan or a global injury. The next classification that we can see on the right is based on the position of the dorsal root ganglion. All right. So now the dorsal root ganglion, you have a preganglionic, okay, and a post-ganglionic lesion. So what is preganglionic? So anything or any injury that is in the neurons, which are starting from the central nervous system, extending to the dorsal root ganglion, okay, that means anything prior to the dorsal root ganglion is a preganglionic injury. And as you can see up, a post-ganglionic injury is in the neurons, which are extending from the ganglion and going towards the effector organ. So any injury in the mid-spinal nerve is called as a post-ganglionic injury. Okay, to be precise. We will discuss about this in the next slide. Now, how do we differentiate whether it is a preganglionic injury or a post-ganglionic injury? Of course, you have the investigations. So you must have heard about nerve conduction studies. So if you do a sensory nerve action potential after a brief period of say 7 to 10 days, you will find that the snap, that is the sensory nerve action potential, will be affected or it will be absent, okay, in the post-ganglionic lesions. Okay, whereas if you consider the preganglionic lesions, clinically, you will be able to see something which is called as a Horner's sign in preganglionic lesion. So what is Horner's sign? As you can see in this picture, so you have something where is involvement of the sympathetic nervous system, okay, of one side of the face. So you may see some things like meiosis. So if you see this, the pupil is completely constricted, right? Or you can see ptosis. Ptosis means what? That your eyelids are drooping, okay? Your eyelids don't like completely open up. And there is anhidrosis. That means there's some failure to sweat, okay? Now, when you consider an MRI, you also see certain changes in the preganglionic lesion, which are called as, this word which you see here is a pseudomeningocele. Now, what is a pseudomeningocele? Now, can you see this? So it's some sort of opening in the dural sac that you can see, okay, you can appreciate here. So that is entrapping the injured nerve roots and all the structures that are coming out. So that is a pseudomeningocele, which is usually present in a preganglionic brachial plexus injury. So you can see that very well there. Moving on. Now, other classification is again based on severity. Okay, so this is the normal nerve root, okay, that is coming out. If you see avulsion, this is again a preganglionic type, because usually from the base itself, the nerve root has come out. There is no stump remaining. So that's usually a preganglionic type of injury. Then you can see something which is the rupture. Okay, so here you can see that this much stump is still preserved, but there is a rupture midway. So this is usually a post-ganglionic type of a lesion, and it is amenable to repair. You can repair this part. Okay, then you have something called as neuroma. What is a neuroma? It is a thickened structure that you see, all right, in the cord. It's like a collection of tissues that happens. Usually, you do not see conduction through a neuroma. That means the nerves do not conduct. But if you see, even good, then you just have to do, the surgeon just has to do a neurolysis and he will be fine. But if you feel that there is no conduction through this, then the surgeon will have to excise the neuroma and use some grafts to allow the conduction. And the last is the neurapraxia. We all have heard about this in the Seddons and the Sutherland's classification, right? So neurapraxia is basically an anatomical continuity, but a physiological block. So there is this slight constriction or, affection of the conduction that takes place physiologically. And that is why for some period of time, say 14 days to 21 days, it may not conduct, it may not show the response we want to see, but you have to allow it that some time to repair itself, and you will be able to see spontaneous recovery in cases of neurapraxia over a period of time. Okay, so moving on, what are the assessments which are necessary for the surgery before the surgery? Okay, in this traumatic brachial plexus injury patients. Now, the first thing is a very good and thorough history has to be taken from the patient and their relatives. So first thing is mechanism of injury. As far as possible, ask the patient to remember how the injury was. So most of the patients of traumatic brachial plexus injury will come up with, road traffic accidents or some kind of bike injuries or something falling, bullet injuries. Okay, all these kind of things usually happen. So what is the mechanism of injury? Why we as physiotherapists need to know this is because we need to clinically correlate later on. Now, if something, as we can see, a hyperabduction injury, a lot of abduction has happened in the shoulder, chances are high that you have injured the lower cord, okay, or the lower trunk, as to be precise. Okay, whenever there's an adduction injury, like there is the shoulder goes into an adduction or the person falls on that shoulder, chances are high that it is an upper trunk injury. Okay, and if it is, say, the neck stretching, okay, you've fallen and the neck has stretched like vigorously, then there are chances that it is like a global or an upper plexus injury again. Okay, usually it is global, more common global in the sense complete injury. So, but sometimes there can also be an upper in trunk injury based on how severe the injury was, okay, or how severe the movement or traction that happened was. The next thing which we need to know is time elapsed post injury. Now, why this we need to know, I will come to that in the subsequent slides. But this is also one very important aspect when we decide the pre-rehab, the surgery, or the post-rehab. Okay. Now, the next thing that we have is the prognosis post-injury. Not every patient is going to directly come to you immediately after falling. Some patients go around to different doctors and then they may come to you after, say, 3 months or 6 months or 9 months. So you need to know what is the prognosis in that period, whether the symptoms have remained the same. Now, so people who have had global injury or complete brachial plexus injury, have they shown some muscle where there is some flicker, something that has improved over a period of time? Or if the symptoms have worsened, on the contrary, the pain has increased, there is more neuropathic pain or something like that, that has to be noted in your history. And of course, the associated injuries have to be very well noted, because sometimes, normally it is with a road traffic accident, so it's not possible sometimes that only the nerve is involved. Okay, there may be some clavicular injury, so you can have some cord which is involved above the clavicle, so supraclavicular involvement of cord or infraclavicular involvement of cord. Okay, so that can also happen. So you need to know if there's any associated clavicular fractures, if there is any associated subclavian vessels injury, or if there is any associated humeral fractures or injuries, we need to know about that in the history aspect. Okay, moving on to evaluation. All right, the first evaluation that we need to do is pain assessment. All right, so why pain assessment? Because definitely nerves are involved. So the pain, the character of pain, okay, neuropathic pain, duration, how frequent is it? Is it continuous or it is on movement? From where to where it is extending? Okay, all of that has to be noted. You as a therapist need to know the patient's pain mechanism before you choose your rehab. Okay, so if you don't know the pain mechanism or the stage at which the patient is, difficult that you will plan the right treatment. So you need to know what the pain mechanisms are dominant in the patient. Now, then we talk about the ranges at each joint. Okay, you need to know the range that is there at each joint, because you're going to plan your rehab or prehab rather on the basis of that. Individual muscle charting, of course, we need to know the individual muscle charting, as we had discussed this, okay, this trunk. So now if suppose we see that probably these muscles which are innervated by these nerves are involved, Okay, and you see that the muscles which are probably innervated by the dorsal scapula, say rhomboids, say the serratus anterior, say the supraspinatus and the subclavius, and all these are intact. So that means, the injury is somewhere lower. Okay, now suppose only the rhomboids and the serratus anterior are intact, whereas some major muscles of the posterior cord or medial cord are also intact. So but then the suprascapular nerve or the nerve to subclavius is probably affected, which is why you're not getting supraspinatus action or some subclavian action. That means you can certain that probably the injury is here. So that is why you have to clinically correlate, which is why IMT, that is individual muscle testing, is very important. You can't do GMT and certain your clinical level of lesion. And if you don't do this muscle charting at each level, you will not be able to clinically correlate with the MRI findings or the EMG findings or any of the other NCS studies that we do. We have to build that correlation. It's not that you will only depend on the investigations. You also have to have a thorough base of clinical knowledge. Coming back, so you will also do a sensory evaluation. Obviously, the nerves are involved. You will have to check the nerves dermatome wise. You may also see certain autonomic changes. You can see some dry skin. You may see some kind of tingling. All of that has to be assessed. Reflex assessment. So you need to check if the reflexes are intact, they're diminished, or any other signs that you are seeing. Okay, you have to do functional evaluation. That is very important. Now, patients of traumatic brachial plexus injury, even after surgery and good rehab, it is very less likely that you will get absolutely pure movements at the end of it. Okay, the main thing we train them is for functional movements or functional activities, such that they are able to do those functional movements. Now, if I'm eating like this, they may have to eat like this a little bit, a little bit trick movements and then do. But our aim is that they should get functional. Okay, at least they should do their activities independently, which is why a prior functional evaluation is necessary. And then you have the aerobic capacity assessment. Okay, now you will think it's a brachial plexus injury. Why do we need to do aerobic capacity assessment? Okay, first thing, he's undergoing the knife. Okay, he's undergoing the surgery. Before that, you have to have this aerobic fitness that is there. Apart from that, we will come to know later what types of surgeries are there. In the surgeries, there are various types in which you take the grafts from respiratory muscle nerves. Okay, say intercostal nerve or phrenic nerve, all of that. Okay, so you have to make sure that you know the baseline of the patient aerobically as well, so that these grafts are takeable or no. You can take these grafts or no. If his aerobic capacity is poor, his respiratory functioning is poor, you have to rule out those grafts. You cannot take those grafts as donors to your recipient muscles. Okay, so that is why to ascertain the aerobic capacity, it is very important. And finally, coming to outcome measures. Okay, we all know that different joints have different outcome measures, different conditions have different outcome measures. Now, for patients of brachial plexus injury, you will not simply take a dash score or any shoulder score or wrist score only. You will also have to take other factors into consideration, like the quality of life. Okay, it is especially now, since these injuries happen at young patients, especially the male population who may be the earning member. There are a lot of psychological aspects. The quality of life gets degraded. A lot of things like that happen. Okay, so you need to choose your outcome measures considering those situations as well, not just the the actual assessment that you do with regards to pain or function or anything. Even the psychological aspects, the quality of life, is equally important to be assessed. So this was about the assessments which we do prior to the surgery. Now, just to show you probably how a person looks pre-operative. Now, this person over here had come about 1 year post injury. Okay, now you can see that this is the normal limb, and you can see that this is the affected limb, right? So you can see the amount of wasting in these limbs. The muscles have atrophied. The limb girth has decreased. You see how flail the limb is looking. The palm, the thumb appears to be in the plane of the palm, ape thumb sort of. You can see these dimples or sulcuses here. Okay, so because your supraspinatus is not there, the biceps is not there, this is the case of global or complete injury, this person. So, and you can see these ribs are also more prominent on this side. The pectoral mass is very much atrophied here. Okay, so now just to zoom into that, you can see the sulcus here. which is not there here. So that sulcus is one thing we have to take care of, that you are not promoting more subluxation or dislocations. You have to be very careful and plan your rehabilitation accordingly. Also, if you see posteriorly, you can see that, there is some rhomboid wasting, there's some serratus anterior wasting, which is why the medial border is prominent. Okay, there's more downward rotation of the scapula, it is more elevated. So all these postural changes are very much visible in these patients. So you have to assess the posture also accordingly. Now, what are the points to consider in your prehab as well as surgeon? The surgeons also consider these points when they are planning the surgery for the patient. One is the age of the patient. Okay, obviously the healing is faster in the younger patients as compared to the older patients. Okay, another thing is the level of involvement. Okay, how much is involved? If only the upper plexus is involved, lower plexus is spared, obviously the outcomes would be better. Okay, vice versa, if it is like the lower plexus is involved but the upper plexus is spared, so that is also probably good prognosis. But if it's a global injury, the prognosis may be more guarded. Okay, there may be good improvement, but maybe a little more slow as compared to just the partial injuries. Now, the next thing what the surgeon is taking into consideration is that if there is no spontaneous recovery in 3 months, then the surgeon explores the brachial plexus injury. Okay, so they have to explore the plexus and find out, okay, post 3 months, if there is no spontaneous recovery. Okay, now if you wait for 20 to 24 months post denervation, what happens is that these neuromotor end plates, they start losing their functioning. Okay, they lose their properties, and that is why doing something like a nerve transfer may not be very feasible. So as we have mentioned, next, the best window, okay, period to do the surgery for any patient is first 3 months post injury, or the subsequent next 3 months you can do, and after that it is a little less satisfactory when it comes to nerve transfer techniques. Though there are other techniques which I found out, but I will basically be focusing on nerve transfers and nerve repairs in this particular session. Okay, now obviously there is a need for availability of good prehab and post-surgical rehab. Okay, if you do not follow those latest advances which have been found, you will not have that coordination or consultation with the surgeon fortnightly about the surgery, about the plan of rehab that you have jotted down, then the patient will not benefit. So it is very essential that you have to form a team with the surgeon, with the social worker, because probably you will also, the patient will require a lot of funds because the rehab goes on for a long period of time. Okay, you may need a psychologist in your team because you need a lot of counseling for the patients. Okay, there are a lot of patients who are young who lose one limb entirely if it is global, and they go into a lot of mental depression and trauma. Okay, there's a lot of stress disorder that you can see in them. So which is why it is very essential that you identify these points early and you have to inculcate them holistically in your treatment plan. Now, just a gist of what investigations we do in the traumatic brachial plexus injury. You generally do a nerve conduction study. So if you do a snap, usually after the injury, 5th day se leke 11th day tak, it completely reduces. So that's the right time after 11th day to do. If you do anything prior, you may misdiagnose it, some wrong information might come. So preferably after 15 days, if you do nerve conduction study, same way your motor amplitudes will drop by 3rd day and it will reach the lowest by say around 7th day. So it's safe to do these nerve conduction studies after say 15 days when you get the accurate findings. Otherwise, if you do prior and the nerve is still in the process of disintegrating and degenerating, you may not get the right, clinical, the right reasons or impressions of the studies. The needle electromyography is best done after 3 weeks of injury. Try not to do it before if you want to see the abnormalities which are actually present. Then the other ones which are the somatosensory evoked potentials, and you have the MRIs which can be done. You also used to do myelograms before, which were gold standards before, but now usually they're not done that often. Now we'll go to the different types of surgeries. Now you must be wondering, why do we need to know about the surgery? We are physiotherapists. But it is important that you know every aspect of the surgery, because a lot of your rehab is going to deal with the type of surgery they have done, what was their donor, what is the recipient which the surgeons have chosen. So that has to be known, which is why we need to know the surgeries before we know the rehab. Okay, so I'll try to cover the nerve repairs and the nerve transfers mainly here. There are other ways also, but this is my main focus area today. So we have intraplexal nerve repairs. Now, as I discussed earlier, if it is just, the root stump is rather, safe and it is distally. So it's a post-ganglionic injury. Your donor roots are available and viable. You can just join them to some trunk or cord as per whatever clinical decision making is done by the surgeons by looking at the various investigations and clinical assessments. And then you use some autologous nerve grafts to join those to the distal targets. Okay, whatever root stumps are there, those. So that is an intraplexal. That means within the plexus, you are going to do certain permutations, whatever suits the surgeon well at that point. Okay. Then you have the extraplexal nerve repair. That means the nerves which are the donor nerves are not within the plexus. Okay, they will be outside the plexus. Now, as you can see the first image here, they have taken the intercostal nerve. Okay, they've taken the intercostal nerve because it's proximity, and they will be giving it to musculocutaneous nerve for biceps. Okay, same way here, if you can see, there is something that is spinal accessory which goes to the trapezius muscle, that is diverted to your suprascapular nerve that goes to the supraspinatus. Okay, so that is your donor nerve, the spinal accessory. This is your recipient nerve. All right. So these are the extraplexal nerve repairs, because these parts, these nerves, which are the donors, are not a part of the plexus. All right. Moving on, we have distal nerve transfer. Now, what are distal nerve transfers? It means that inside the plexus only, there's some technique which is called as Oberlin's technique. Okay, so now sometimes when the patient is only, say, an upper plexus involvement, all right, so the lower plexus is still intact, so the ulnar nerve, the median nerve is still intact. So what they do is that they probably take the graft or from the ulnar nerve fascicle, okay, and they give it to the musculocutaneous nerve here. Same way for the biceps function. Same way, there is something called Somsack's technique. All right. Somsack's technique, basically you take a branch of the long head of triceps and then you give it to the posterior division of axillary nerve for deltoid. Okay. So your donor is your long head of triceps branch, which is given to the recipient, which is your axillary nerve, posterior division. All right. Moving on to the next one, which is the contralateral C7 transfer. So when there is a global avulsion, what they do is that they take the nerve root from the C7 aspect of the normal side or the unaffected side, and they coapt it to the affected side. All right. So this is usually done in global injuries. Now, what are these nerve transfers based on, and why are we even reading about it? Okay, the nerve transfers are based on the principle of neuroplasticity. I'm sure you guys have heard what neuroplasticity is. All right, neuroplasticity is basically the different, the ability of the brain basically to, adjust to those changes that happen. Okay, perceive to different stimuli. So the brain is constantly adapting, and there are structural changes, there are some functional changes. So the ability to brain to sort of adjust to whatever new changes have happened is neuroplasticity. Okay, now what happens is that in these nerve transfers, you are invading the deafferentiated areas, means whatever areas where the nerve is affected, you are kind of using a donor and you're invading into that area so that you are sort of giving it that nutrition or that supplement to work. Okay, some sort of substitute to work. So that is a nerve transfer from one donor area which is functioning well. You keep it to the recipient area which needs it to function. Okay, so that is why the nerve transfers we study, because our rehabilitation as we come later is going to be based on this. All right. So the distance between the cortical areas of the donor and recipient neurons is very important. Now, in the functional MRIs, if you may have heard about it, okay, it is seen that whenever your recipient area is trying to, contract or something. So suppose if it's like the intercostal nerve is given to the biceps, musculocutaneous nerve. So you may see that whenever the person is probably trying to do an elbow flexion, he may have some activation in the intercostal nerve area also of the brain. So those kind of things are considered. The distance is considered in the cortical areas before they do the operation, before they do the surgery. So they need to know the distance of the cortical areas between the donor and the recipient, in which case I gave you between ICN and MCN. They need to know that distance. They need to know if there's any presence of any interneuronal connections. Okay, they need to know if there's any brain trauma associated with it, any age-related issues, and what kind of rehabilitation is given will all benefit your nerve transfer, which has been done, and the patient gets the results well. Now, before the surgery, a very important aspect, rehabilitation or prehab, which we call it. So that is the rehabilitation before the surgery. We need to understand what surgery has to be done or what surgery the surgeon is planning to do. What would be the donor? Okay. Now, like if we know that ICN is the donor, okay, for the patient, which is going to be given to the biceps, we have to start strengthening the respiratory muscles, which are innervated by ICN or intercostal nerve. So for that, we will want to give a lot of breathing exercises, strengthening exercises, aerobic capacity improvement, all of that. All right. So that is why knowing what surgery is to be or is planned is very important, so that you strengthen the donor's nerves, muscles. Next thing that we need to do is maintaining the passive range at all the joints. Okay, if you do not have the functional range that is present in the joints, you will not get good results after surgery. So before surgery itself, you have to make sure that all the joints have good range. So as you see, shoulder flexion has to be trained, abduction has to be trained, elbow flexion has to be trained. You need to train for shoulder rotations as well. You have to train for forearm rotations, you have to train for wrist movements, and not just that, even work on the web spaces between the fingers. The thumb needs to be stretched. All of the joints have to be worked on, especially if it's a global injury or a complete injury. If there is partial injury, obviously you will work more on strengthening and range. Okay, but active range that is there on the preserved parts and passive range on the parts which have been affected. But if it's a global, as I said, all joints have to be given good passive range. Okay, considering the associated injuries as well, like any fractures and all of that as well. All right. The next part is splintage. So you can give a shoulder sling or sling, which you can say. As we had discussed earlier, there can be some sort of subluxation, some sulcus sign may be positive. Okay, in those patients, you don't want it to increase. Also, we don't want that the hand is constantly hanging down. So, some edema comes in the hand. So you give them a sling, okay, for support. And you can give them a resting pan splint as well, so that the hand is resting in a functional position, and it's just to protect the hands and the fingers as well. Okay, skin care has to be taken care. Sometimes there's dry skin. You need to make sure you moisturize the skin. You ask the patients to moisturize them well. You need to do some desensitization. Sometimes the patients may have different kinds of autonomic symptoms that may happen over the skin, some kind of burning, some itching, all of that may happen. You have to make sure you give them good desensitization methods to get rid of those autonomic symptoms. The next thing is pain control. Of course, the first thing that we need is pain management. Okay, so you can surely give them TENS, which is along the level of pain. So you can apply linearly wherever the patient is feeling pain, you can linearly apply. But now you have to take care. Okay, sometimes patients may not understand the intensity, all right, because the sensations are lost. So you have to make sure that when you are applying any kind of electrical modalities, you need to know how much intensity you are giving. You have to feel yourself being normal. So make sure it is given at a tolerable intensity, especially for the ones who cannot feel any sensations. Okay, it shouldn't happen that, you give at a very high intensity because he's not feeling anything, without knowing that he has lost sensations over the part, and then just causes some undue burns or any electrical issues in the body. Okay, so you have to take care of that. Of course, as we discussed earlier, there may be issues with posture and balance. Okay, because of these alterations that you see here in the trunk, okay, or the shoulder girdle rather, there would be alterations in the trunk, in the pelvis, in the legs as well. All right, so you need to work on their posture as well as balance. Even the neck muscles, you have to work on the chin, the neck posture and all of that, with the chin tucks and whatever muscles are there around which are active and still you can strengthen them, they have to be worked on. The balance has to be improved. It has been proven that dynamic balance is affected in these patients. So you have to train them on that. You can also give electrical stimulations to the muscles. Again, keeping them in mind, if the person has complete denervation over the part, you may have to start with interrupted galvanic current. Okay, and you can give, say, Faradic re-education once he develops that grade 1, maybe. Why do we need to do that? Is because you need to maintain the muscle properties till the time the surgery happens, or sometimes, even in cases of neurapraxia, you want to facilitate the healing, you can give them stimulation. But again, I repeat, if the person has any kind of loss of sensations, it is very important that you give it very carefully. You do not just undue increase the intensity, because if the patient does not feel it, okay, and you just keep on going on increase, there are chances of burns, okay, and skin damage. So please make sure that you know how much you're giving in certain patients who cannot feel the current. Now, this part is the most important part of your rehab. Okay, how well you counsel the patients. Okay, about their status, about their post-surgical therapy, every single thing has to be counseled upon. There will be patients who are young, okay, who suddenly lose a limb, so much of mental trauma, so many questions to ask. And it is your duty as a therapist to give them time to listen to the queries which they have, which are related to their surgeries, okay, or related to their rehab. Explain them that it is a long process, it's not an overnight process. Okay, it doesn't happen overnight, that the surgery is done and the next day the person is fit and fine. No, it takes time for the nerve to grow. Okay, nerve grows at 1 millimeter per day. It takes a good successful surgery to get a good outcome. It takes good rehab, not just from your side, but some compliance from patients and their relatives as well. So all these aspects have to be touched upon. You may also want to, there'll be a lot of patients who live in the villages who come to the cities, okay, to do their rehab or even for the surgery. So they may have to live here, for a long time. So you may have to help them, or explain to them that, you have to live in this city. So that also incurs certain expenses. Okay, the rehab may be expensive at certain places. So all of that has to be explained. You can make the patient meet some social worker. You can take the patient to a psychologist as well, where the person is counseled. Beyond your counseling level, there's a psychologist who can help the person get rid of his mental anguish. Okay, coping strategies, all of this has to be well developed, and the patient has to know the importance of good follow up and rehab post surgery as well. Okay, and you have to be the link between the patient and the surgeon. You have to update the surgeon every now and then about what rehab has happened with the patient and how he is improving, or there is no change that has happened, or there is, on the contrary, deterioration. Every single thing has to be reported to the surgeon. Okay, so it's a teamwork, and if there is no good teamwork, then there is no successful outcome that can be achieved. So what are the general questions which are asked by the patients very commonly? Okay, why am I not able to move my limb? That will be before the surgery. Why I'm not able to move my limb? So you can probably keep some chart or some kind of a model, which can explain, where you can explain the patients which nerves are coming, what is innervating the upper limb, and when you will be able to move. You may also have to explain the patient that, your movement may not be as normal as it used to be before, but, we are trying to take you to the more functional level. Okay, how many days of rehab he may have to undergo. You have to explain that it's a long-term process. How many times to exercise. Now, every person is different. Okay, some may have partial injuries, some may have complete injuries, some may be young, some may be old, some may be cognitively sound, some may not be able to do the exercises. So every single aspect that they ask, whatever answers you give have to be convincing, to the point, and it has to be relevant to the rehab of that particular patient. It has to be absolutely tailor-made. All right. Therapists should take the following points into consideration. So one thing is keep the patient motivated. Okay. Now, because obviously, as I discussed before, some patients may be the sole earners of their family. Okay. They may be in complete anguish. One complete limb is not there. Maybe they were laborers. They used their hands. You have to keep patients motivated. You can always tell them about alternative methods of employment that they can do at their level of education or skills or whatever. Okay. You have to keep them motivated. If there is no positivity in the patient, then you will not get your results as you would get in a positive patient. Okay, so that willpower is very necessary to be kept generated. That fire has to keep burning inside the patient to get better. So it's your duty as a therapist to keep them motivated. All right, you need to explain the need of each and every exercise you're doing. Sometimes some exercises are so scientific that patients may not understand what am I even doing. As we come into the post-surgical aspects of rehab, certain exercises you're not actually doing something to the hand, you're something doing to the brain. Probably some mental activity will involve the patient, and he will think, why am I doing this mental activity? The problem is with the hand and she's not touching my hand. So that is where the role of explaining the importance of every exercise to the patient comes. Okay, he or she should be aware of what regimen is being followed for him. Third thing is you need to empathize with the patient. Okay, there may be certain days they may just come, have an outburst. Okay, they may just feel anguish or mental stress, or they may just come and cry to you about something. So sometimes you have to, or like most of the time, you have to empathize, give a listening ear to the patient. Okay, you try to motivate the patient, keep that person positive. That is your aim as a therapist. Okay, direct towards the right ways of rehabilitation. Despite so many advances in rehabilitation and all of that, if you as a therapist are continuing to do the conventional ways of treating a brachial plexus injury, then we are not taking them to the right ways of rehabilitation. So you have to know that you will discuss with the surgeon, you will discuss about the progress, you will ask about the surgery the surgeon is planning, you will make your rehab protocol accordingly, you will discuss those points with the surgeon. You will you can probably inform the surgeon that there sometimes what happens is brachial plexus injuries surgeries happen in steps. Okay, one complete surgery may not recover the patient completely, so you may have to go for step 2. So probably now, since you are seeing the patient after the first surgical treatment, okay, you are seeing the patient, you may want to you may know now these are the improvements that have come over a period of time. So you may want to tell the surgeon, see, now probably these improvements have come, so probably he does not require the next surgery, or maybe this is the right time to do the next surgery. So it is not just one way communication, it is a both way communication. And with a good team only, there will be a successful rehabilitation, which I'm repeating again and again. So there has to be good discussion and communication, open channel communication between the surgeon and the therapist, and other aspects also. Even an occupational therapist has to be involved, a psychologist, a social worker, all these people, pain doctors, pain medicine doctors needed to be involved for the pain management. So it has to be a holistic approach. So just to summarize the prehab, we have passive movements, we have splintage, we have skin care, pain control, posture and balance improvement, electrical stimulation of muscles, and very, very good counseling, okay, which is important aspects of your prehab. All right, moving on to the next part, which is your post-surgical rehabilitation. Now, again, post-surgery, the patient may come to you, say, about 3 to 6 weeks later. Okay, so certain surgeons believe in immobilization for 4 to 6 weeks. Okay, so again, you will have that open channel communication with the surgeon as to when we can start mobilizing. All right, because obviously intraoperative status, the surgeon knows better than you. The surgeon has operated the patient and knows what kind of suturing has been done or any of that sort. So he will be able to tell you that, the immobilization period is for say 4 to 6 weeks, and thereafter you can start your rehabilitation. You need to use the sling again for the initial time, because you can't keep the hand hanging down, because that can also cause failure of the surgery. You have to explain to the patient the number of times they have to do the exercises. Again, that will vary on different factors. Again, level of lesion, what kind of surgery is done, how good the cognition of the patient is. Okay, sometimes you don't have to be over enthusiastic also, and at the same time you don't have to be under enthusiastic. There has to be a right optimal level of doing the number of times doing the exercises. Okay, and you have to prevent any kind of overstretching or anything at the joints. So they can use the shoulder sling, and sometimes there are surgeries like trapezius transfer, not the nerve transfer, the trapezius muscle, a certain fascicles of it may get transferred to get that. So what happens is the surgeon will ask them to use this aeroplane splint to avoid adduction. They want to keep it in abduction because your trapezius from here is going here. Because if you do that sudden adduction, you may fail the surgery. So that is why in such patients, whenever you're treating, you will never take them down to adduction immediately after 4 or 5 weeks. Even the adduction is brought down very gradually, say about 10 degrees every week. You will not suddenly get them down. That will cause the failure. Okay, so about 10 degrees each week, you will get that down slowly into adduction. You will work more on the abduction till then. All right. Now, this is a very, very, very important part of your rehabilitation, which is donor-assisted focused rehabilitation approach, which is the DAFRA technique. All right. Now, you may have thought why we were talking so much about the surgery. This is the reason why we need to know what surgery is being done. So these are called as induction exercises. So we need to know what the donor is. We need to activate the donor, and with the assistance of donor activation, we will cause recipient action. All right. Now, immediately after surgery, now for shoulder function, what surgeries are done? You generally have a nerve transfer of spinal accessory nerve, which is from the trapezius, which supplies the trapezius. You give it to the suprascapular nerve fascicles, okay, which is to supraspinatus. So what will happen is shoulder abduction and external rotation is your normal supraspinatus action, barabar. What is the donor action? Donor is your spinal accessory nerve, which is given, which gives supply to your trapezius. So your elevation is your donor action. Now, since we have given help from spinal accessory to suprascapular nerve, what we will do in induction exercises is we will activate the donor first. Okay. So in this case, we will activate the shoulder girdle elevation, which is your trapezius action. And that will initiate the shoulder abduction. All right. So initially, obviously, the patient will not be able to do shoulder abduction and external rotation because just surgery hua hai. So for the nerve to grow and all of that will take time. So what you'll do is you'll actively ask the patient to do shoulder elevation, but you will take the person into abduction. But you will at the same time mention, try taking abduction, try taking into abduction, try taking the hand out, taking the hand out. I'll show you the video subsequently. Probably you'll get a better idea. So initially, maybe the recipient action would be passive, but you have to still, give those commands. Try to take your hand out, try to take your hand out, because once the nerve grows, all right, probably someday, maybe say after 4 weeks or 5 weeks post starting the rehab, he may be able to show some flicker in abduction. All right. So that is when you know that your surgery is successful, your rehab has moved in the right direction. All right. Same way, there is the next surgery as we spoke about Somsax. Okay, where you take the radial nerve of the triceps, long head of triceps, which is action is elbow extension, and you give it to the axillary nerve for abduction of deltoid action. So what you'll do is you'll do elbow extension as you extend like that. You'll do elbow extension as you do abduction. Sorry. You'll do elbow extension, which is the donor action, as you do abduction, which is your recipient action. Okay, so if you can see this video. So as we saw in this video, what we did was we activated the donor muscle, which is the spinal accessory nerve action, which is trapezius action, which is shrugging the shoulder, while we take the hand into, or the limb into abduction, correct? So why we take into abduction? Because supraspinatus action is abduction. Now, initially, post-operative, patient will not be able to do abduction. Okay, so it is your duty to take it passively, but you will still instruct the patient. Why is that instruction important? Is because the brain understands movement and not muscles. So over a period of time, as the nerve grows, when the patient will probably be able to initiate, that means that the slowly the renervation is happening into the recipient part as well, and you will be able to eventually get that muscle strength over there in the recipient as well. Okay, even supraspinatus will be able to activate. So initially you will do the donor action, okay, and go to the or achieve recipient action because of donor action. That is the main part of induction exercises, which is why we need to know the surgery. Now, what are the surgeries which are done to improve elbow function in general? Which is the intercostal nerve. Okay, intercostal nerve, as we discussed before, goes to the nerves to biceps. Now, biceps is what? Elbow flexion action, which is missing. The intercostal nerve is going, the action is active inspiration. So while I'm doing active inspiration, so like I take a deep breath, I will ask the patient to do the biceps action. So again, as I repeat, biceps action may not be present initially. You will have to passively take it, but actively he has to do the inspiration, okay, till the flicker comes. Once the flicker is achieved, then you take the patient into, say, side lying and try to do it in gravity eliminated plane. Okay. So basically, the main gist here is initially you are doing some sort of mass movements, and then you go into dissociation movements. So mass movements in the sense you are activating the donor and then you are doing the recipient action. You're not doing a pure recipient action. Okay. So it's more like impure movement. It's not like a motor. It's not having good control. But we need that movement to happen. We need that donor to activate so that the recipient eventually starts activating over a period of good rehab. Okay. Same way you have the median nerve fascicle, okay, which is given to the biceps. Again, that is Oberlin 2. So what you'll do is the median nerve action you consider as fisting or wrist flexion. So as I want to do this flexion, which is the recipient action, for donor, I will ask them to do wrist flexion. So in lower, when the lower trunk is preserved, okay, median nerve is preserved or the ulnar nerve is preserved, I will ask them to actively do the wrist flexion, and you will first passively take the elbow into flexion, which is the recipient action. So while I'm doing this, I will take it into flexion. While I'm straightening, you can open. Again, while I'm doing that way. Same way with ulnar fascicle, you will probably ask them to do ulnar deviation of hand, and then you ask them to do a flexion. All right. So that's how you can work on the donor action, thereby leading to recipient action eventually over a period of time. All right. So initially you will work with the help of donor, and slowly you start dissociating the movements. You go for more purer movements once you achieve that flicker in the recipient muscle. Okay. Just look at the video. So as we see here, the median nerve is transferred to musculocutaneous nerve as in Oberlin's technique. So what I asked the patient to do the fist as I'm trying to passively take the shoulder, the elbow into flexion. Okay. So once I achieve that flicker, maybe I'll ask the patient to do actively initially, and then slowly start dissociating it into only pure elbow movements. Okay. Once I know that it's like a little more than flicker, then you can dissociate and start doing more of individual recipient action. So it's like initially you do association and then you make sure you go into dissociation. All right. So now the electrical stimulation of recipient muscles. So as we had discussed before as well, even pre-rehab, you do the long pulse duration current, you go to short pulse duration. When the muscle power is 0, okay, you will use an interrupted galvanic current to bring about the coordination. So what you'll do is that, interrupted galvanic. So as you get that contraction, you may have to plan your recipient action along with it. All right. So now again, some patients, as I told you, may not have those sensations. So you have to probably see that contraction. Even if that contraction is not coming, if you know in the multi-stimulator that we use, there is that light that flickers when the current is coming. So you have to look at that light, and when that light comes, you will initiate the recipient action. So when the muscle power is 0 to 1, you can use Faradic current. Okay. So that means it is grade 1. So Faradic re-education can be slowly started. So now as you can see, if suppose the biceps is affected, okay, you have the musculocutaneous nerve which is not there. So recipient pay, you will keep those 2 electrodes, okay. And while you see the contraction, when the contraction is going on or the current passes through there, you will give them that flexion. If at all, for any reason, you're not able to see the contraction, if I'm repeating again, you will look at the multi-stimulator, you will see that light, okay, when it flickers, that means the current is coming now. When it stops, that means the current is not going. That's when you'll relax the elbow. Okay, when the light comes, you will cause the elbow flexion to happen. Okay, again, repeating, the intensity has to be very, you can say judiciously chosen, because you don't want to cause any kind of burns to the patient, because they may not able to feel any kind of sensation. All right. Moving on to the next part, which is motor imagery or the graded motor imagery. Okay, we know that we have the 3 steps, which is your stage 1, that is implicit motor imagery or left-right discrimination. Okay. Now, if you remember, I was talking about this thing, sometimes patient may not understand that you're not doing anything to the limb. Instead, you're doing something, working at the mental levels. This is what I was talking about. Okay, so left-right discrimination is implicit motor imagery. Now, because of all the neuroplastic changes that happen, over a period of time, there are a lot of changes that happen. The limb has not been working for a while, and then there's a surgery that happens, and it's working in a particular way now. So then what happens is those neuroplastic changes happen in the brain. So the representation of hand images are shown to the patient, and he has to identify the left and the right. So there may be differences in the left-right discrimination also. It may look like ye kya hai, ye to simple hai. But sometimes when you show those pictures to them, they may not be able to suddenly make out whether this is my left hand or this is the right hand. So that has to come. Now, how do we determine whether the whatever things have been said by the patient is right or wrong? So already there are preset number of cards that are given to the patient. Okay, you already know what is right and left. So you will note down all the responses of the patient. Okay, so 2 things are taken into consideration. One is the accuracy, which is the number of right answers, and second is the reaction time. So if the accuracy is above 80%, that means 80% of the cards were, found out to be right or were guessed right. That means the patient is normal with regards to implicit motor imagery. Or if the patient has a reaction time of less than 2 seconds per card, that means the patient is normal. If he's taking more than 2 seconds per card, that means it is not normal. Okay, that means there is some impairment in the left-right discrimination that has happened in the brain due to the neuroplastic changes that have happened post-injury. All right, moving on to the next part, which is explicit motor imagery. Explicit motor imagery is basically imagining the movement. Okay, so I'm just thinking like the patient, one hand is completely not moving, and I'm just asking the patient to imagine that, just imagine that you are bending that elbow. So what happens is, now in this particular technique, in the functional MRIs, it has been found that even imagination of such movements without actually doing the movements has also caused the activations of the respective brain or cortical areas. So that eventually helps in the movement development later stages. Okay, so that is one thing that is taken into rehab. And eventually you have mirror therapy. You may have heard of this, especially in phantom sensations, correct? So you keep a mirror or a mirror box. Okay, you keep your affected hand behind the mirror, and you keep your normal hand in front of the mirror, and you sit in such a way like your normal hand image in the mirror looks like your affected hand. Okay, so you will do certain movements in the normal hand. Okay, you will see the mirror from this angle, you will do the movements in this, and you will imagine that the reflection of that normal hand movement is actually your affected hand moving, while your affected hand is just placed behind. Okay, that itself stimulates a lot of activation in the mirror neurons in the brain, and thereby helps in your rehabilitation and gentle or gradual development of some activations in the muscles over a period of time. All right. Then something that is constraint induced movement therapy. You may have heard of this in a lot of stroke patients. It is being done. This is possible in patients who have, say, partial injuries or so. So what you do is that you constrain the normal hand. You don't allow the normal hand to move, and you have to force the patient to use as much as possible the affected hand. Now, there is a little glitch here. Now, usually when you give this constraint-induced movement therapy to patients of complete brachial plexus injury who have not been operated or who have been operated but still have not shown any results, then patients may go into some sort of, they may feel horrible after some time because they will not be able to move at all. So you need to choose who you're giving it. You don't want to make the patient frustrated as well in the therapy, but at the same time, you want to initiate the use of the affected hand as much as possible. So once you know that a certain amount of strength has been achieved, in the affected hand, you can try putting that more into use and use constraint-induced movement therapy. But as far as possible, do not give it on patients with global palsy where there's absolutely no movement, because you're going to induce more frustration and aggressiveness in the patient, and he may not comply to your therapy. So you need to choose your audience or of patients whom you're going to give constraint-induced movement therapy. And then we come to crossover therapy, which again works on the basis of irradiation, which was developed by Sherrington. So basically activating the contralateral side, okay, facilitates relearning on the affected side as well. So it has been seen that whenever your strong activations are given to the contralateral side, in fMRIs, they have also seen that the activation of the affected side also takes place. So you need to know that, whatever and everything and anything that works for the betterment of these kind of patients, it is very important that you put into practice. Okay. And the other aspects of rehabilitation are desensitization technique. Okay, sometimes patients are like too hypersensitivity, too much hypersensitivity. Their skin is like hypersensitive. You need to desensitize those. And sometimes if there is absolutely no this thing, you may want to, feel the patient all the different textures, starting from, coarser textures to finer textures or whatever the patient is able to tolerate. Okay, you may want the patient to feel it over that skin. All right. At the same time, you can give very gentle neural mobilizations, okay, for the neuropathic pain, but a little later in the rehab, so that any kind of neural constriction within any soft tissue that can be mobilized. Okay. Just to summarize, I think post-surgical rehabilitation, we need to make sure that our patient education is on board, very well done education with a whole team. Okay, the entire team has to educate the patient, not just the physiotherapist alone, the surgeon, the social worker, the psychologist, the occupational therapist, all of them have to be a part of the team. They have to have appropriate splintage. You need to have a donor assisted focused rehabilitation approach in place, which is your induction exercises, for which we need to consult the surgeon to know what surgery has been done, go through the post-operative notes. All right, you need to go for electrical stimulation, again with care, making sure if the patient sensations are affected, you will take care of it. All right, you will want to go for graded motor imagery and progressively go into constraint induced movement therapy. Once you achieve some movements in the upper limb, to ensure more use of upper limb, you can use crossover therapy, that is use of the contralateral side, normal side, to strengthening of that side to get the action over the affected side, and eventually desensitization and light neural mobilizations can be started. So basically this kind of ends my lecture, but I would like to end it on this note that no matter how much theory you read about this, it is only well understood when you practically experience treating these patients. And it is not a very easy task to treat these patients because mind you, they will always have questions. Everyone always wants to go back to their normal functioning life. It is that phase of life when you sort of feel very grateful to what you had before the injury. So they will always have this question. They will always have those hopeful, eyes coming to you and asking, that whether they will ever get back to normal, completely normal. And you as a physiotherapist, since they are coming to you for a longer time as compared to probably the surgeon, because for rehab, they have to keep coming to you. Your role lies most important over here in shaping their personality, giving them guidance, giving them good rehabilitation, providing whatever help you can in whatever means is available to you would really be very helpful in their overall rehabilitation. So I would like to end this session by thanking each one of you for having attended it, and thank you to Team Physio TV for having me here. And it was a pleasure to present this topic, and I hope that all of you have learned a considerable aspect of brachial plexus injury, though some things may still require a lot of reading and understanding to understand it completely. But surely I think if the best is the patient who will teach you at the end. So do try to develop your hands-on and understand the skills by yourselves as well, apart from the theoretical reading. Thank you.
That was a wonderful session, ma'am. Thank you. This enlightening session will help all of us in our clinical decision making. I would like to thank Dr. Parag Sancheti, our chairman, Mrs. Manisha Sangvi, our executive director, Dr. Apurva Shimpi sir, our principal, and the whole Physio TV team and technical support. I would also like to thank you all audience for such a warm support. Thank you so much.